I want to welcome Dan and Weaves to our debate. You guys heard the rules. Dan, you'll get to start first with your 5 minutes, and your 5 minutes starts now.
Great. Thank you, Patrick. Really appreciate the invite. And I'm going to share my screen here. I have one slide to talk through. So just a quick background. I'm the Director of Safety and Epi at Carelon Research. It was recently rebranded. Health Corps was its previous name. And as part of my work, I do a lot of safety and effectiveness related studies, and many of the studies involve chart review. And so I'm arguing the pro chart part of the argument. And I think there's a few key points that I think relate to this. So I think the idea behind chart validation is we're concerned about information bias, and in particular outcome misclassification. We know that this can greatly diminish study validity when we think about our safety or effectiveness related studies or comparative studies. It can bias results to or away from the null in either direction, and sometimes greatly if there's a lot of bias. We know when working with claims data and developing phenotypes, these are often imperfect. It's prone to both false negative and false positive error. So there's been a number of validation studies over the years. I know the Sentinel group did systematic reviews of this many years ago. And while it certainly varies depending on the phenotype, but many of them, right, have low accuracy, lower PPVs when measured. Some have lower sensitivities. Suggesting there could be meaningful bias when using these phenotypes. This bias can also be non-differential, but it also can be differential by exposure. And I think both are potentially, important, but especially when we're thinking about differential by exposure, comparing different drug groups, right? There could be reasons such as differences in healthcare access or quality, differential diagnosis, rule out diagnosis. For example, if you think about comparing a newer drug that's just on the market to an older drug for a safety outcome, maybe clinicians may be more cautious of the newer drug and worry about concerns about a safety outcome that they're aware of, and use kind of a rule out diagnosis approach more often than the older drugs. So these can be differential. And chart validation in brief, right, is helpful because it's an independent source of data outside of the claims data that can do a few things. It can assess the accuracy of the phenotype. You can develop a revised phenotype within that validation study, especially if you're designing in a specific way. And you could use that data. It's maybe not as commonly done as of yet, but you can certainly use data from validation studies to, in your comparative study, adjust for that misclassification, that information bias, using quantitative bias analysis techniques. And I think one of the challenges in our field is, especially when working with less common, rare safety outcomes, it's hard to get at specificity, right? But there are quantitative bias techniques, I cite here Brenner and Geffler, particularly, that use positive predictive value and sensitivity that you can use to correct or adjust for this misclassification. And you can design your validation studies in a way, it may take a little bit larger of a validation study, but you can design it in a way that you could get estimates of PPV and sensitivity, even for less common safety outcomes, and then use those in the comparative study to adjust for your effect estimates. And so when you're thinking about this question of ensuring reliable evidence, thinking about, changing people's healthcare decision-making specifically, you often would want a very high bar, right? And having a second independent source that has clinical information, things in the notes, things like lab data, other things that you could more reliably determine a outcome or condition, and then use that to be able to adjust your study is a more reliable and trustworthy way of getting really robust evidence. So I'll leave it at that.
Great, thank you, Dan. So we heard on the side of source chart review adjudication being necessary. Now we'll hand it over to Jamie Weaver, who will try to provide 5 minutes of an overview of why source chart review may not be necessary. Weaves.
Thank you for providing all that info, Dan. Appreciate it. So I'm going to try to be provocative. So if I say something that makes you uneasy, that is by design. So bear with me. My first is a disclaimer that I haven't participated in chart adjudication-based validation studies before or dealt with any of their associated difficulties and logistics. So forgive me for speaking cavalierly about this, since I haven't actually done one myself. I have, however, spent tons of time with data-driven methods for developing and evaluating phenotypes in collaboration with all sorts of multidisciplinary stakeholders, including clinical experts who've bought into this kind of approach. I will assert that this approach can and should be also called validation. What I think is a helpful analogy is that in real-world evidence estimation studies, we try our best to meet an ideal, and that ideal is that our study meets all the assumptions of exchangeability, positivity, and consistency, and we go and apply a design and analysis specification intended to achieve this ideal. But given the particulars of our particular research question and the observational data that's available and all of the methodological assumptions with our tools and so on, meeting these ideals is never not compromised somehow, and you always write about this in your limitations. Validation studies are no different. The FDA has blessed us explicitly with the ideal of complete verification, in quotes, where the value assigned to every variable for every patient in every study is based on a medical record review gold standard. This is mercifully acknowledged as infeasible given the realities of time and resource constraints. So even when a really motivated investigator with all the time and money in the world wants to perform a study where one variable, like an outcome, has a complete case analysis, every record's validated, getting even like half, 60% of the requested charts is usually what you get at best. So like in an estimation study, these validation studies, we kind of need to approximate the ideal because we're never going to have a perfect one. So fully evaluating a phenotype really includes getting trustworthy and accurate errors, including all of PPV, NPV, sensitivity, and specificity. And to do this, we need to first develop or obtain a clinical description of the condition that everyone involved agrees upon. And this requires strong clinical knowledge and background on presentation, diagnostic evaluation, therapeutic plan, and prognosis. You have to develop your algorithm that's intended to represent this condition and apply the phenotype algorithm to return patients for validation. And then you assess the performance of this algorithm by comparing the patients returned by your algorithm to a reference standard. So the choice of reference standard is subject to debate, including this one. So I'm going to push this idea of using a probabilistic reference standard approach. In this approach, you fit a diagnostic predictive model that discriminates extremely specific cases from a general population with potential cases removed. So think of this as a database population minus a extremely sensitive population or a screening population that Dan has introduced in one of his papers. So you apply this diagnostic model to a large evaluation population of intentionally noisy case and non-case labels, where everybody does not get a 1 or 0 case or non-case label from a clinical adjudicator, but rather a probability of case status. So then you populate a confusion matrix with the sums of conditional case probabilities by the algorithm case status. So for example, say you need a denominator for a sensitivity calculation where you need true positives and false negatives. We can get our false negatives as the sum of probabilities among patients who don't qualify for the phenotype algorithm that you're evaluating. And then the nice part about this is tool is flexible, and you can stratify your evaluation population by exposure status to get those pesky differential errors that are so influential in changing estimates that are subject to error. You can also do this by time or population or anything you want. The flexibility is great. The merits of this approach is that it really facilitates rapid, large-scale, multi-database temporal study and exposure-specific measurement error ascertainment that's just not possible to do quickly using chart adjudication. You can assess performance and transportability across databases where populations vary by composition, care-seeking behavior, care patterns, and everything associated with time. And lastly, it really facilitates the validation of multiple outcomes that you can assess in one single estimation study that's executed across multiple databases, which is highly relevant given the current context of large heterogeneous distributed data networks full of rare.
Weaves is cut off, but he got a good set of opening round punches in there. So well done, Weaves. Thank you for the 5 minutes. I ask everybody to consider any questions that you have for Dan or Weaves, and I'll be looking at those to post their 1 minute questions. But first, Dan, you get 2 minutes to respond to Weaves.
Great. No, I appreciate the comments, Weaves, and I think we're getting at a similar, and I think the approach you describe, right, it's getting at the similar problem of trying to address information bias, outcomes classification. And I think you brought up a few good points. I think the approach that you're describing using probabilistic modeling, I think fee evaluators maybe one in this model as well, where you can be done more rapidly and probably with less expense, right, than chart validation. I think that is true, right? But I think the challenge with that approach is that, again, you're using this, I believe, the same source of data for that form of validation. You're being very rigorous and thoughtful, and I think addressing the issue, but using charts, you're getting a separate source of data that has clinical notes, that has lab data, that has other things that could lead to more confidence that we're accurately identifying, the gold standard basically for a condition. And so while it may take longer, it may cost more money, right? If we want to be really confident and have very reliable, trustworthy evidence that can change people's decisions in terms of which drug to take or other things like that, sometimes it's worth spending that extra time and spending that extra money to be more sure about being able to address this misclassification. So I think what you described is a good way to address it in some ways, but has limitations, and it could be bolstered further by doing chart validation.
Great, thank you, Dan. And Weaves, your 2 minute response to Dan.
With pleasure. You hit on some of the limitations of fee evaluator that I was going to say had I had more than 5 minutes. And those are namely that the predictive model is only as good as the input data, which we know in observational claims and EHR data is incomplete, messy, and biased. So, you get what you pay for. The full context that you can get from a chart interpreted by a human with intelligence that can easily and effectively scope problems and ignore irrelevant info that can confuse predictive models is, truly gold. Like we know that, there are some cases where prediction can approximate how well clinicians can do, especially in radiology applications. But like the clinician approach to reviewing a chart is the gold, and I agree with that. But it just doesn't scale. So like researchers need to really consider the context that we're in when making the trade-off between getting a really good source of external validation through a chart or using or getting error metrics from the actual study data that we're using and getting it done immediately, especially in this large heterogeneous distributed database networks context that we're in. And an example for that is like the Darwin Initiative, where there's going to be like 100 incident studies done a year, 50 estimation studies done per year, where there is not actually going to be a feasible way to use external information. And then my last point is that the developers of all of these methods for error correction, like QBA or integrated likelihood estimation, they all say that the greatest impact on their methods are the accuracy of the error metrics themselves. And if they've been created by a solid validation study 10 years ago in a database far, far away, they might not actually be applicable. So that trade-off to me.
That trade-off to him is going to be a mystery to the rest of us. But thank you, Weaves and Dan, for your 5 minutes and 2-minute retorts. I'm now going to select one question for each of you and have you have 1 minute to respond. Dan, so it sounds like you both are basically agreeing that this is all about estimating measurement error and incorporating that into an analysis. But the question on the table is really about the value of source data. So Gautam asked the question, how do you know that the source data has better data, more detail, more accuracy, additional attributes about patients versus the extracted or abstracted structured data like claims and EHR are already providing? What if the data is not actually incremental, but is only noise? How would you respond to that?
Yeah, no, I think that's a good point. Interesting question, right? It may depend a bit in terms of, I think the one way of phrasing that is if we're using charts as our gold standard, right? Maybe they aren't necessarily gold. There is some ambiguity to charts as well, right? But I think for many conditions, right, there's been a lot of validation studies, a lot of clinical criteria that's used can be obtained in charts, and they're not available in my experience in claims. Sometimes there are things in the clinical notes and other things that are truly novel and not in the claims for these things. So I think there might be on occasion some studies where there is a very tarnished gold standard for charts, but for many studies, there's been many validation studies that have suggested they can be used as a helpful reference standard.
Very good. Thank you, Dan. And Weaves, Andrew asked the question, under what conditions would you not trust something that didn't have a chart review?
There's some double negatives there. Under what conditions would I not trust something that has not had a chart review?
That's right. Are there circumstances where you feel a chart review would be necessary? Would be the positive non-double negative of that.
Yes. Where there's all the time and resources in the world, and you don't need your answers quickly, which I would argue is not very often. That we've had a few situations where there's not been a lot of time pressure to get evidence generated, but that has been much more infrequent than situations where you need the evidence sooner rather than later. So I would say that the situations where you actually really need a chart review based validation study are basically few and far between. You've got lots of time, you've got lots of resources, and you've got access to internal, like the same data on charts for the people on whom you're doing your study. So like in that situation, which I say is rare, is one where you need it. And in other situations where that is hard to come by, other approaches would probably be necessary, and I believe it to be true.
Very good. Thank you, Weaves. Thank you, Dan, for both being good sports. The last thing we've got, we'll just go 1 minute over, as I'd like to share the screen and ask the rest of the community. There's 172 of you still on the call, so please share your opinions. If you have been swayed by Dan that source chart review adjudication is a necessary component of phenotype evaluation, please vote at pollev.com/PatrickRyan800. And if you are taken by Weaves' argument that there are maybe alternative ways such that source chart review adjudication is not necessary component for phenotype evaluation, then please vote B, negative, I don't agree. We'll take one last minute here to collect the votes of the community. I'll have to say that it sounded like, for the most part, you guys were violently agreeing on the value and importance of measurement error. So it's really just a question of where do we go get that measurement error. But it was good to hear the different perspectives. We had 33% of the crowd was on the fence before this debate started. And we're now seeing some of those people come off the fence. I'll give 30 more seconds for the final vote. All right. And with 55% now supporting the argument that source chart review adjudication is not necessary, Jamie Weaver is the winner of debate number 2. Congratulations, Weaves. Dan, you did a good job of preserving your 50% of folks that were still feeling like it is necessary. This still clearly, by being almost a 50-50 margin, suggests that there's quite a lot of more work we can do as a community to figure out the role of source chart review. But clearly, your violent agreement on figuring out how to estimate measurement error is a good area for us to all be collaborating on together. I want to thank Dan, Weaves, Harold, Anna for being good sports, for playing with our Odyssey debates today. Thanks everybody for participating in the discussion. Hope that you all learned as much as I did, and I'll turn it back over to Craig.